This is Heart Rhythm TV, and I'm Daniel Alyesh. Welcome to Breaking News. AHA 24 happened recently, and we received the much anticipated results of the Option clinical trial, which sought to study the role of left atrial appendage occlusion in conjunction with ablation as compared to DOAC anticoagulation. And it was an illuminating trial. And for that reason, we're joined today by Dr. Oussama Wazni, the lead author of the Cleveland Clinic. Welcome.
Thank you, Dr. Alyesh. Thank you.
So a one-to-one international multi-center open label randomized clinical trial involving 1,600 patients, approximately 800 in each arm. Congratulations on a great study.
Thank you.
I'm going to start off with having you describe overall the study you performed.
Yeah. So, thank you, Dr. Alyesh. So Option was really one of the big trials now in atrial fibrillation ablation studies. So the reason we thought about Option was this issue of what do we do about stroke prevention after an ablation? And this is an issue that has not been addressed very well. There has been inconsistent data. And it really is a very important thing for our patients. Our patients, will ask us after an ablation, okay, I don't feel any AFib. Should I continue oral anticoagulation? And because of the uncertainty, the guidelines right now, as they stand, they say that after an ablation, the decision to continue or discontinue oral anticoagulation really depends on the CHA2DS2-VASc score and not on the perceived outcome of the ablation. And this is a problem because you can have a patient who says, I don't have any AFib, but they may have silent AFib, and we stop their their anticoagulants, and they end up with a stroke. On the other hand, you can have a truly successful patient, meaning a patient who really is not having any recurrence of AFib, and you continue the anticoagulation based on the CHA2DS2-VASc score and the guidelines, but they can end up with a major bleed or continue to have, other bleeding that they have to go to the doctor. And we're not doing them any favor because they don't have AFib, so the risk of stroke is really low, but we continue their anticoagulant because we don't know any better. And that was the really motivation for us to do the Option trial. And we thought, okay, now that we have a device that can close the appendage and reduce the risk of stroke, would it make sense for us to consider closing the appendage and not having to worry about or have to address the issue of stroke prevention? We prevent stroke, and at the same time, we decrease the risk of bleeding. So that's where Option came from. And so we conducted the Option, 1,600 patients. We started enrollment November of 2019. We finished enrollment end of June of 2021. So during COVID, I mean, there was a lot of anxiety around COVID, whether we're going to be able to finish the trial. But frankly, because of the motivation of the patients themselves, they really wanted to know, and our doctors, the EP community wants to know, we were able to actually enroll ahead of schedule and finish enrollment. Then we followed the patients for 3 years, and then we presented the outcomes at AHA with a simultaneous New England Journal of Medicine. The good news is that they were balanced here. This is the slide on the background characteristics. Patients were balanced. 95% of them were taking DOACs. And also, I wanted to point out the CHA2DS2-VASc score was 3.5 in both groups, and 10% in the device group and 11% in the anticoagulation group had a previous TIO or stroke. So these were not low-risk patients.
Thank you. I also want to point to the viewers, you had 95% on DOAC, and this is the first major trial comparing to DOAC.
Yes.
And then you look at the breakdown of the types of anticoagulants, pretty reflective of clinical practice. About 60% Eliquis, 30% rivaroxaban, et cetera. Also, CMS approved the concomitant Watchman or occlusion and ablation code this year, and the majority of the patients in the study, however, were more sequential, right? And then about 40% were concomitant.
Yes. So we can clarify here a little bit that the CMS code is for currently indicated patients. So meaning patients who have an indication for an ablation, and the current indication for left atrial appendage closure, which is in a patient who needs stroke prevention but cannot take long-term oral anticoagulation, meaning those patients are bleeding. These are not our patients in Option. In Option, our patients did not have a contraindication or an appropriate rationale, if you want, for long-term oral anticoagulation, so they're able to take anticoagulation. And the study was designed in a way that we want to allow patients who've had an ablation already to also get an opportunity with this, because those are the patients who are going to come tell you, okay, I had an ablation, 6 months ago or a year ago, but I have to continue this blood thinner. Do I really need to continue the blood thinner, or is there an alternative? At the same time, also what I was interested in, because we've been doing this at the clinic for a long time, is the combined approach. Does it make sense that since we're going to be ablating those patients, does it make sense to combine them, do them together? Now, we stratified per whether it was sequential or combined, and then the data came out the way it is. Frankly, we were hoping that we would get, I don't know, 20, 30% concomitant, but it turned out to be 40%. So I was actually very happy when the results came out and that 40% of the patients were combined, because we can build on that experience and see whether this is a reasonable approach or not.
Absolutely. So going to your primary efficacy endpoint, meeting non-inferiority, all-cause death, stroke, systemic embolism at 36 months. Elaborate on what you found and the design here.
Yeah. So it's very important to remember why people do non-inferiority studies. So the reason non-inferiority studies happen is because you have a new device or therapy that has certain attributes that are better than the old therapy. So what is it about Watchman that could be better than taking DOACs, for example, or anticoagulation? One, you don't have to take an anticoagulant every day, so compliance, you're protected, hopefully. Two, because you're not taking an anticoagulant, you'll have a reduction in bleeding. But why is it not inferior? Because we're not sure that it's going to be as effective as the old therapy. So that's why you're thinking, okay, well, but if it is as effective, but you have all these other positive attributes, maybe it is a reasonable alternative. So that's how we think about this. Now, there's a lot of talk on, well, okay, non-inferior, why the margin is 5%. The margin is 5% because of previous studies with Watchman versus oral anticoagulation that showed that, maybe it's barely as effective. But also based on the other studies, we thought, okay, what would be reasonable? Like, is it worse by 5%? Would that still make it to the point that you would say, no, the positive attributes, the benefits of those are better than this non-inferiority margin? So we picked 5% based on a historical evidence, meaning that if the device group was worse by up to 5%, we would still say it's not inferior. And here, the outcome actually was very encouraging because numerically it was actually less. So very far away from the 5%. It's actually minus 0.5%. Now, some other people will say, okay, well, why did you pick death, stroke, and systemic embolism? Because again, this is the best data we have from previous studies. And they say, well, why did you include death? I said, what if, putting a device caused more death? When you want to have, you need to have death in it. What if, for example, by implanting a lot of device, people have effusions and all this, and they have problems? Wouldn't you want to include that in the endpoint? Now, stroke, we will talk about it later. Of course, this is what we want. We want to look at stroke in these patients and make sure that it is not, that such a strategy does not result in even more strokes. So that's why this is the endpoint. But again, going back to our margin, 5%, even if we decided on 2%, for example, that if it was worse by 2% for the composite, this numerically being lower tells you that it is so non-inferior that it is, great. I mean, to the point where we can say, well, maybe if we designed it differently, it would have been superior. Who knows? But we didn't do that. And then again, non-inferiority is just, there's so many negatives. So is it unacceptably, to a point higher that it is not inferior, and it's not. It's actually very acceptable because we didn't even get close to that non-inferiority margin. And again, the 5% was chosen based on the previous studies. Now, some people say, well, you should have picked 2%. Maybe, okay, 2%. And the question to everybody then would be, would 2% have been acceptable? Like if Watchman was worse by 2%, would you still use it given the other attributes? And that's where, the safety endpoint comes into play. Again,
So,
yeah.
I wanted to actually dive down though a little. Oh, first off, thank you for that important clarification, Dr. Wazni. Um, you know, the stroke rate around 1.4, 1.5%, hemorrhagic stroke, less than 1%, I think 0.7%.
Yeah.
I'd ask you to comment a little bit about our traditional thinking about arrhythmia burden post-ablation. What contribution does ablation have to the lower stroke rate from your perspective?
Yeah, so this is a very important question. So if you take, for example, the different components of the efficacy endpoint, and I had presented that at AHA, the ischemic stroke risk was 1.2% in the device group and 1.3% in the anticoagulation group. Very low in the CHA2DS2-VASc group of 3.5. True. So yes, I think ablation does lower the risk of stroke. It does. The problem was that even with all the data that is out there, the guidelines still said, because of the uncertainty and because of the inconsistency also of the data, that regardless of the outcome of the ablation, successful or not, you should continue anticoagulation based on the CHA2DS2-VASc score. So it is true, but we didn't know that going in with designing this. We didn't know that this is how low it's going to be. We didn't. There was nothing to go by, and that's why the guidelines were written the way they were. If there was some more and stronger data, then the guidelines would not have been written the way they were. And remember, when people sit down to do guidelines, they go through reams of data and studies and all this. And with all of that review, the best they could come up with is, we don't care what the ablation outcome was, continue anticoagulation if the CHA2DS2-VASc is 2 or higher.
Absolutely.
Yeah.
So moving on to our next discussion point, your primary safety endpoint, which you alluded to, non-procedural ISTH, major bleeding. Tell us about what you found.
So this was now the superiority endpoint, and just like you said, it is major non-procedural major bleeding and clinically relevant non-major bleeding. Now, I would like to clarify here again that most of this was driven by the clinically relevant non-major bleeding, but this is not minor bleeding. It's just that it's non-major, and that's why it doesn't say here clinically relevant minor bleeding. It says clinically relevant non-major bleeding. And this was defined also by the ISTH. There's a whole paper on it. So what does it mean? It means that the patient had to seek medical care because of that bleeding. So it wasn't some little cut that or did you have a cut and we put that in our CRF. It was bleeding that the patient either needed to have a face-to-face conversation, by the way, not like this, not what we're doing right now, virtual. It was face-to-face conversation. They had to go to the ED or change the therapy. So this bleeding that did affect the patient. And also then major bleeding. And we found, frankly, 18.1% high in the anticoagulation group versus 8.5% in the device group. And this met superiority. Now, some people will say, well, why didn't you include procedural bleeding here? And that's a good point. But this is how device studies are done. The reason is that there are other things beyond the device that can cause the procedural bleeding. Meaning, if somebody is not very good at getting access, yeah, that would be a major procedure. But you can't say that the device did not function the way it is. And here I want to take this opportunity, because people don't know this, is that in the device group, there were no pericardial effusions related to the procedure, that index procedure itself. If you had effusions later related to other procedures, for example, a patient had a PVC ablation later and had an effusion, but they were in the device group, so it counts towards the device group. But it's really very reassuring that even when you take into, procedure bleeding, that was also very low because we all got better at getting access, at getting transeptal, and also implanting the device. And the device is a lot better. The flex, it gives you the opportunity to reposition it without having to exchange again. And I think it's a really much safer design also.
I think the ISTH endpoint is a good one. It's validated by a major society, and I think for those of us who take care of patients, this is the reason why they want to stop anticoagulation for these sorts of events. This impacts adherence. So clinically, it makes sense. And so I want to just piggyback on your comments.
Thank you.
So this slide is diving into the supplemental materials a little more.
Yeah.
Looking at anticoagulation over time. And I'm going to juxtapose that next to the successful closure rate and leak rate. About 10% of patients over time did remain on anticoagulation. And you remarked that about 80% of the patients had successful closure, meaning no leak at 12 months. Now, this is pretty similar to the Pinnacle Flex study, but I'd like you to kind of elaborate on what were the size of the leaks, what was the impact of the leaks, why did some patients remain on anticoagulation?
Yeah, so the biggest reason that patients continued on anticoagulation, and by the way, these are not the same patients. So the 10% is at any one time were taken anticoagulations, and they're not the same patients. So it's not the 10% and stayed. And this informs us then about the leaks and whatever. So it's not that there were 10% with leaks and then we decided to keep those patients on anticoagulation. The reason the 10% were on anticoagulation at some point was because they needed more things to be done. For example, a cardioversion. So we still don't know, even if you have a device, people now practice differently. They would restart anticoagulation and do the cardioversion and continue. So or for example, a redo ablation. So that is the majority of those patients. It wasn't because of leaks or DRT. Now DRT was very low. It was 1.9%. The other one, the leaks was 20%, which is a bit higher actually than Pinnacle. But that's because we allowed people to look for it using CT scan, which is a lot more sensitive. But at 45 days, the leak rate was the same. At 1 year was higher because towards the end, because at 45 days, they all had to have TEE. And then later, they could have had a CT scan or a TEE. So that's where this discrepancy comes into. But regardless of the leaks or the DRT, the risk of stroke was very low, 1.2%. Anyway, in this. So as a strategy, and remember, we're talking about big strategies now. So does the strategy of closing the appendage make sense? To me now, it does make sense.
Yeah, I think, this will take you to the final point, which is the conclusion. I think that the title of your study absolutely kind of indicates what we would give to our patients. It does give them an option. I think this is the first major clinical trial looking at a comparison to DOACs and also looking at it in conjunction with ablation. So I want to congratulate you on a great study.
Thank you. No, thank you. So I think the most important thing now is really the patients have choices and their doctors have choices. And I'm not advocating that every single patient after an ablation should get a Watchman Flex device. I think it is safe to say we talk to our patients, we tell them about. I mean, if they ask about it, most of them will ask about it, believe me, by themselves. But even if they don't, we can tell them that there is an alternative now. Now, who would that patient be? Yeah, it could be a patient who right now doesn't have an issue, but you think because of age, for example, somebody who's 75 and starting to have difficulty with ambulation or gait or all that. I mean, that's a very good, option for them. Sorry for using the word again. But yes, I think those are patients and do it. And then also even younger patients may tell you, listen, and also we have, again, going back, this is not the end of the story. The patients keep getting older and they develop new things. So if they have this alternative, why not? The other thing I want to say is we will continue to collect data on all of this and see whether this is something that will continue to be beneficial. For example, the original Protect and Prevail studies they did not show a mortality benefit against warfarin. But then at the 5-year follow-up, because again, this can happen with time, it showed that there is a mortality benefit. Now here on the slide, you have Champion AF. I think this is for everybody. I mean, for everybody, it's going to be a good thing, depending on the findings. Can you replace all patients' oral anticoagulation with matchment flex? We have to wait until 2026. LAAC 4 is actually like a strategy that I like a lot. It's like LAAC 3, where you close the appendage and continue anticoagulation in the very, very high-risk patients. But then if you have to come off the anticoagulant for either bleeding or, for example, in preparation for surgery, at least the patient is protected. And Catalyst will basically do the same thing, but with the amulet instead of the Watchman.
Yeah, I think that this is an important piece of data that you presented. And I think, the key with any randomized clinical trial is replication, right? Multiple randomized trials, understanding the clinical question in many different contexts. So that's why I included this future direction. But I want to conclude by congratulating you on a great study. And thank you all. Thank you for joining me today. And thank you all for tuning in to Heart Rhythm TV.
Thank you so much, and hope to see you soon, you guys. Thank you. Take care.